everyone. Thank you so much for joining us today. My name is Heather Price, and I'm the Substance Abuse Prevention Specialist for the South Lakes High School Pyramid, and I'm joined today by...
Hi, I'm Allie Jacoby. I'm a Substance Abuse Prevention Specialist for the Woodson and Marshall Pyramid.
Hi, I'm Anna Teeter. I'm the Substance Abuse Prevention Specialist for the Falls Church Pyramid.
So today we're going to be talking about the complex topic of THC oil. We researched for hours trying to gather and verify the information we're presenting today. There's so much information on the internet, and it's difficult to know fact from a sales pitch. We know it's ever evolving and more research is being done, so we wanted to start off with that disclaimer. We know and understand information regarding THC oil will continue to change and evolve. All right, so let's start with some definitions. The first one is cannabis. Cannabis, which is simply a family or genus of plants that contain cannabis sativa, cannabis indica, and cannabis ruderalis. They can be identified by the look of their stalk, flowers, and leaves. As you can see in the picture, hemp and marijuana are species of cannabis that we will also define in the next few slides. So you've probably heard of hemp. It only comes from the sativa strain of cannabis. The federal government defines hemp as having less than 0.3% of THC. It can be used for many, many things, as you can see in the graphic, everything from a rope to granola. All right, so we all know what marijuana is, but the definition from the Merriam-Webster dictionary is that marijuana is the dried resinous flower buds and leaves of the female hemp or cannabis sativa and cannabis indica that contain high levels of THC and are smoked, vaped, and ingested for their intoxicating effects. So that brings us to THC, or tetrahydrocannabinol. THC is a substance that is responsible for the effects of marijuana on a person's mental state, or in non-technical terms, it's the stuff that gets you high. Some cannabis contains very little THC, and under U.S. law, that's considered hemp and not marijuana. Okay, so CBD, or cannabidiol, has been everywhere for a couple of years now. You can pick some up at the local Safeway without a prescription. CBD is the second most prevalent of the active ingredients in cannabis. It's derived directly from the hemp plant, the cousin of marijuana. CBD on its own does not cause a high. Now on to concentrates. As you can see from the graphics, there are quite a few variations of concentrates. Many different textures and forms, but concentrates are simply defined as an oil, concentrate, or extract derived from the cannabis flower and typically have a high percent of THC. Concentrates can be dropped under the tongue in tincture form, taken in pill form, and can be vaporized. It also comes in hash form, which can be vaped or smoked, and then shatter, wax, and other oils can be ingested and used in food. This finally brings us to the main topic. THC oil. THC oil is made by extracting the resin of a female marijuana plant with the help of alcohols. THC oil is known for its high concentration of THC and can vary depending on strains. A lot of these terms are very similar, but we're hoping we are able to give you a better idea of the small differences. We briefly went over this in the last slide, but just to drive the point home, the most important difference between THC oil and traditional marijuana is potency. Traditional marijuana is about 10 to 25% THC concentration, while THC oil has 50 to 90% THC concentration. In my experience, students have told me they can't find anything less than 80%, and typically they believe they're getting up to 95% THC concentration. We're focusing on oil because the majority of discipline referrals are from THC oil, which brings us to the next slide. THC oil has become popular with youth. It's so incredibly convenient and easy to use that, as you can see in the graphic. That device can easily fit in a pocket, and it does not smell as strongly as traditional marijuana. In 2018, 11.8 million young adults used marijuana in the last year, and the number of daily users increased. The potency and convenience of THC oil is a concerning combination that we will have to continue to see the data on. As we've mentioned, THC oil concentration has increased over the years. In this chart, you can see that in 1995, it was a mere 12%. And we see the average in 2019 has jumped to 53.63%. That's an average of what the DEA has seized over the years. As we know, THC oil can be as high as 95%. This is not 1960s weed anymore, which contained around 2% of THC. How THC oil can impact a few of the common diagnoses we also see in special education. The first diagnosis we're going to talk about is ADHD, attention deficit hyperactive disorder. ADHD is a common diagnosis in special education that you're probably familiar with. The main symptoms of ADHD include lack of concentration, short attention span, and physical restlessness. There are many complex behaviors associated with ADHD, and a lot of those are impacted or influenced by THC use. ADHD is associated with the need for reward and lower dopamine levels, and cannabis releases dopamine at high levels that make someone with low dopamine feel great. People with ADHD sometimes have difficulty making friends, which in turn causes them to have low self-esteem, making marijuana a group activity that could be attractive in order to gain an automatic peer group of other THC users. ADHD is associated with poor impulse control, which is related to poor refusal skills. ADHD is also associated with sleep issues, and THC is associated with helping people relax and sleep. Students often state they use THC to help them sleep. Between the behaviors associated with ADHD and the convenience of THC oil, along with the information that is pro-THC, we can see why teens with ADHD are attracted to THC. Studies have shown other correlations between ADHD and cannabis use disorder. People with ADHD are 2 times more likely to have cannabis use disorder than people without ADHD, as well as 2 times more likely to have ever used marijuana. Another study showed that 33 to 38% of people with cannabis use disorder had ADHD. And another jarring study found that 53% of non-daily users and 57% of daily users have ADHD. And now I will finally pass the torch on to Anna to tell you a little bit more about ODD and THC.
So even the best behaved children can be difficult and challenging at times, but a child or teenager that has frequent and persistent patterns of anger, irritability, arguing, defiance, or vindictiveness towards an authority figure could have oppositional defiant disorder, ODD. We're looking at a period of at least 6 months, and there's certain diagnostic criteria in the DSM-5 that professionals use to diagnose ODD. People with ODD or conduct disorder diagnosis will sometimes break the rules and defy social norms, which can include substance abuse at a younger age. Adults and even teenagers that are suffering from severe aggression may self-medicate with marijuana. A lot of times students with ODD view this as the only or best way to calm themselves down from the disruptive behaviors that stem from their disorder. When someone has a mental health diagnosis and a substance use disorder, this is called a co-occurring disorder. And treatment professionals should always focus on a holistic and comprehensive approach to treat the disruptive behavior disorder and the co-occurring substance use disorder for the best results for the student.
All right, so now we're going to talk about how THC affects the teenage brain for students with TBI. So according to the Virginia Department of Education, TBI stands for traumatic brain injury, and it means an acquired injury caused by an external force resulting in total or partial functional disability or psychosocial impairment, or both, that adversely affects a child's educational performance. TBI applies to open or closed head injuries resulting in impairments in one or more areas, such as cognition, language, memory, attention, reasoning, abstract thinking, judgment, problem solving, sensory, perceptual, and motor abilities, psychosocial behavior, physical functions, information processing, and speech. So we'll now go into the risks of adolescents using marijuana and TBI. So adolescents with TBI have increased risk for using substances, including smoking marijuana, partly related to impairments in their executive function. Marijuana can negatively interact with prescribed drugs to treat TBI. This can be dangerous for teens because the effects of mixing common medications with marijuana can have dangerous side effects on a person's heart, brain, as well as their mental health. So additionally, marijuana can interfere with medication schedules, so speeding up or slowing down the effects of prescribed medications. Marijuana use may act as a neurological stressor during TBI recovery. So marijuana and TBI pose risks on the developing teenage brain, including potential vulnerability for developing psychosis. So the high potency marijuana, an example being THC oil, is found to be related. Effects of TBI cause difficulty thinking, balancing, remembering, and concentration. So teen use can help worsen these effects and increase potential for future injury. So there is a lot of different and recent research showing how marijuana can provide alternatives in treatment for TBI, but the long-term effects and potential for addiction for younger people cannot be overlooked. So more recent studies are emerging suggesting that the use of medical marijuana for TBI for adults could help minimize secondary brain damage, neurobehavioral function, working memory performance, and TBI survival rate. But like I said, the data is still limited and emerging. But I do want to stress that smoking marijuana during adolescence and before the brain has fully developed and add on having a TBI truly increases the risk of all these factors for teens that we just talked about.
THC cartridges. So when we look at THC cartridges, we have to focus on both the regulated and unregulated markets as well as the supply chain. Although we are seeing more states legalize marijuana for people 21 and above, many states do not have legal marijuana. This, along with people under 21 in legal states, gives the unregulated market a lot of business. So we see about 78% of the THC market remains untested and out of control. More than 95% of North America's illicit vape pen hardware, so the actual cartridges that the THC is in, is manufactured to China and sent primarily to Los Angeles, where wholesalers distribute the cartridges to people that actually fill them up with THC, CBD, or nicotine. So along this unregulated supply chain, we see that these cartridges are filled up with whatever the seller wants to fill it with. It's not necessarily just filled with pure THC oil or pure CBD. They're often mixing it and making the cartridges in places where there are no regulations on how clean the facility has to be. So people can make these THC cartridges in their homes, in their basements, in their bathrooms, in very unsanitary places, where the regulated market that makes these cartridges have to follow the standards put in place by the state. The unregulated supply chain remains completely out of control and unsanitary. And this is really what we try to tell the students is when you get a cartridge, you don't know what's in it or where it was made and manufactured. So tainted oil. Drug dealers make a significant profit off of adding dangerous additives to the cartridges, which can lead to pulmonary injuries and deaths. So when we see additives in cartridges, we call this tainted oil. If you look at this breakdown of an example of why sellers do add additives to the cartridges. So if we see 1,000 milliliters of THC can cost anywhere from $6,000, possibly even more than that. And by adding vitamin E oil for only $50, they can increase the volume of their supply by 30%. So now sellers have 1,300 milliliters of THC oil by only spending $50 more. This is really, really scary because that vitamin E oil is one of the main contributors to a serious lung injury or a death, and they want to make more money, which is something else that we try to stress to the students that we work with. We also tell them to beware of the packaging. So you see on the slide, sellers buy these by the tens of thousands from LA wholesalers, and they combine them to make some sort of bizarre national brand presence, which makes a lot of sense because brand recognition is a really well-known marketing technique. So you might see these dank vapes in various states from Michigan, Georgia, Nebraska, Pennsylvania, Virginia, but each of these contains a cartridge made by an independent street market manufacturer. So again, these vape companies aren't actually companies they're all individual sellers that are trying to trick the consumer.
All right. So we are now going to talk about EVALI. So EVALI stands for e-cigarette or vaping use associated lung injury. This term was created in response to a multi-state outbreak of severe lung illnesses cases. The EVALI outbreak began in June 2019 and peaked in September 2019. But the number of cases has since continued to decline, but there are still new cases and deaths that are being reported. So health officials point to vitamin E acetate, which is an additive in some THC-containing e-cigarettes, as the primary cause of EVALI. Vitamin E acetate is sometimes used as a thickening agent in vape liquids. And it's important to note that there are many other substances and product sources in vaping materials that are being examined as possible causes as well. It's just vitamin E acetate is the primary cause. So symptoms of EVALI are similar to those in other respiratory illnesses. So these include shortness of breath, cough, chest pain, fever and chills, diarrhea, nausea, vomiting, rapid heartbeat, and rapid and shallow breathing. So if you look at the bottom right of the screen, you can see a picture of a normal lung compared to an EVALI vaping lung, demonstrating the extreme effects vaping can have on a user's lung. All right, so this slide shows different elements of data related to EVALI patients. So to the right, you can see percentages of EVALI patients based on age. So patients under the age of 18 is 15%, ages 18 to 24 is 37%, ages 25 to 34 is 24%, and ages 35 and above is also 24%. So the median age of those hospitalized was 24, and 76% of patients were between 18 and 34 years old. So the EVALI outbreak primarily affects young adults, which is truly driven by the use of the THC-containing products from informal sources and vitamin E acetate that it contains. So if you look where the red arrow is pointing on the chart, you can clearly see that the age group of 18 to 24 has the highest percentage of EVALI patients. As of February 2020, a total of 2,807 hospitalized EVALI cases or deaths have been reported to the CDC. And as of February 18, 2020, 68 deaths have been confirmed. Patients as young as 13 have been diagnosed with EVALI, and the youngest to die was 15. In regard to the THC use among EVALI patients, 82% of patients reported using any THC-containing e-cigarette or vaping products, and 33 reported exclusive THC-containing product use. All right, so now we're going to talk about data relating to teen marijuana use, specifically in Fairfax County. Alcohol, tobacco, and marijuana are the most commonly used drugs among youth in Fairfax County. Overall, 10% of youth reported smoking marijuana in the last 30 days, and 9% reported vaping marijuana, but that number greatly does increase with age. So based on the results from the FCPS 2019 youth survey, 2.5% of 8th graders, 9.9% of 10th graders, and 17% of 12th graders reported smoking marijuana in the last 30 days. Compared to the national average data, FCPS students using marijuana numbers are lower, but definitely not by much. The overall percent of FCPS 12th graders who report smoking marijuana is only 5.3% lower than the national average of 22.3%. So in addition to this information, 94% of students who thought their parents disapproved of them smoking marijuana did not use marijuana. But among the students who thought their parents were okay with using marijuana, only 50% of the population did not use marijuana. So we'll talk a little more about the impact of parental disapproval throughout this presentation. All right, so here's a general chart from the FCPS youth survey showing percentages of students who have vaped anything in the past 30 days. But I just want to briefly point out the statistics on the top right of the chart. So according to this survey, in the past 30 days, 1/5 of 12th graders vaped nicotine, while 15% vape marijuana. All right, so this information represents data about high school students who are currently using marijuana. This data comes from the CDC's Youth Risk Behavior Surveillance System, which monitors priority health behaviors and experiences among students in our country. According to this survey, 21.7% of high school students were currently using marijuana in 2019. So in 2017, 19.8% of high school students were using marijuana. So this data shows that there was a 1.9% increase in high school marijuana use between 2017 and 2019. So this information represents data about high school students who have ever used marijuana in general. So according to the CDC, in 2019, 36.8% of high school students reported ever using marijuana, and this was a 1.2 increase from the data from 2017, in which 35.6% of students reported ever using marijuana. All right, so this information is more specific to the Substance Abuse Prevention Specialist Program. So here's the referral data from the 2019 to 2020 school year related to the SAPS program, specific to marijuana, cannabis, THC, and CBD referrals. These referral numbers are specific to students with SPED eligibilities. So there were 12 referrals with students who had a 504 plan, 16 referrals for students eligible for emotional disability, 44 referrals for students with a learning disability, 1 referral for a student with other health impairment, and 3 referrals listed under the other eligibility. I do want to point out that these numbers are only partially the data that we're hoping to project and to collect just due to the students no longer being in the building due to COVID-19.
So continuing on COVID and THC oil. So as we get further into this pandemic, more research is coming to light about the way COVID affects people who vape. So there are certain early findings that Stanford posted in relation to vaping and COVID-19 in their most recent research. They found that vaping suppresses your immune system, making the lungs less ready to fight a COVID-19 infection when you vape. The lungs actually produce more ACE2 receptors, which acts as a doorway for the virus. It's been found that people who do vape have an abundance of ACE2 receptors to serve as a gateway for more virus to get into your body and for it to replicate quicker, which can make you more vulnerable to severe COVID-19 symptoms. Those who reported smoking and vaping and that were hospitalized due to pneumonia from COVID-19 were less likely to recover, and this means that people who vape are suffering from long-term effects from COVID. The risk of transmitting the virus is also greater since your fingers are in contact with your lips more often from holding the nicotine product, and then your fingers could also easily be in contact with a surface that has COVID-19 droplets on it. Also, the risk of transmitting the virus in general to other people is greater if you're sharing a nicotine product. And we see a lot in our discipline referrals from FCPS that many students do share vape devices with each other, both in the school building and outside of the school building. So this is a really big concern in a world where we're really making sure that we stay socially distant and not share germs with other people.
Now we're going to talk about the role of prevention, specifically how risk and protective factors influence teen marijuana use. So risk factors are characteristics on different levels that precede and are associated with a higher likelihood of negative outcomes. Some general risk factors associated to marijuana use in teenagers include having friends that use marijuana or other substances, low academic achievement, lack of school connectedness, history of trauma or loss, parental substance use, parental or personable favorable attitudes towards marijuana, lack of parental monitoring, biological family history of substance use, mental and behavioral health concerns such as anxiety, depression, ADHD, other things like that, as well as family rejection of sexual orientation or gender identity. Protective factors are characteristics associated with the lower likelihood of negative outcomes or that reduce a risk factor's impact. So data from the FCPS Youth Survey reinforces a lot of research that shows that when youth have protective factors in their life, they do better in lots of different areas. So having just 3 protective factors dramatically reduces the likelihood that youth will engage in risky behaviors. The Youth Survey also shows that every protective factor does make a difference. Some general protective factors in teen marijuana use include school connectedness, involvement with sports, recreational activities, as well as other productive activities, confidence and self-esteem, self-regulation skills, refusal skills, parent or family engagement and support, parental disapproval of marijuana use, parental monitoring, involvement with the faith-based community, and emotional support at home.
So next we're going to transition into what we do as substance abuse prevention specialists. So I did want to mention that each school pyramid has an assigned substance abuse prevention specialist or a SAP assigned to the school to provide substance abuse prevention, education, and intervention services. So one of the most key roles a substance abuse prevention specialist plays within FCPS are intervention services. So intervention services can be both disciplined and non-disciplined. A discipline would be if a student had a violation of the student rights and responsibility. So for example, bringing drugs, alcohol, or vape onto school campus and being caught by an administrator, and then they are referred to us. So we also take non-disciplined referrals, which is if there's a student that has suspected substance abuse, A counselor, parent, teacher, friend, or even the student themselves can refer themselves to work with us and get some extra support. So both during the discipline and non-discipline interventions, we provide education and counseling around substance abuse, and most importantly, we build relationships with the students. We know building a relationship and connection is one of the most beneficial things that we can do to support FCPS students struggling with substance abuse. We also assess the student's level of substance abuse using an assessment tool, and based on the results of that, we can refer them to further services through our partnership with the Fairfax County Community Service Board. So that can be additional group therapy, individual therapy, or family therapy with the Fairfax CSB. And another big part of this job, especially during this time of COVID-19, is prevention work. And we know that educating the community, parents, students about alcohol, tobacco, drugs, refusal skills, and other mental health related information can be really beneficial from preventing substance use in our students.
All right, so how do we help students who are using THC oil? How do you talk to your children about it? How do you talk to your students about it? We suggest that you look for windows to start the conversation proactively. So that's before they get in trouble, younger age. We say usually like 5th grade, 4th and 5th grade, you can start having the conversation about it. And like we have talked about, the big protective factor is parent disapproval. So having that conversation, probably wouldn't too much before 4th grade, but, talking to your children, as often as you feel necessary. Moving away from the morality of it and focusing on the science. So, less about drugs are bad, you're bad if you do drugs, and looking more into the science and saying, like things like your brain is not developed until you're 25 years old. Like, let's give it an opportunity. THC can really affect the maturity of your brain. So let's look at it from that angle instead. Try to understand why your child is using marijuana. That's a big one for us. A lot of times we ask, what does it do for you? We'll hear it helps my anxiety, it helps me sleep, it helps me calm down, it helps me with my stress. So, looking at it from that angle and figuring out, are there other alternative activities that we can do that are healthier for you to help with those issues that you've mentioned? Validate the benefits, but emphasize the cost. Again, yes, maybe it helps you sleep, but using it, again, is not helpful for your brain. It doesn't do good things for your brain before the age of 25. Is there something else, an alternative activity that we could do that would help you sleep rather than using marijuana? Remembering that weed from years ago is different than today's THC oil. As we talked about, the THC concentration in products today are through the roof. So it's different, and it's not just a little weed anymore. Promote healthier coping skills and skills to say no to peers. So as we talked about, the refusal skills are huge. A lot of times we practice refusal skills with our students. We often tell them, blame the school. The school's watching me. I can't use, sorry, the school's watching me. Mom's watching me, dad's watching me, parents watching me, guardians watching me. And that usually allows them a little bit of time to feel better about saying no. And we practice it sometimes, just having that kind of conversation. What if someone comes up to you and offers it to you? What would you say to them? How could you say it and feel comfortable? How could you say no and feel comfortable? And then explain the differences between using cannabis before age 25 versus after 25, which we've talked about. The brain is done developing at age 25, or mostly done developing at age 25, and there is a difference in long-term outcomes if you use before 25 versus after 25. And we often tease our students that you can do whatever you want after you turn 25, but just give your brain the opportunity and chance to develop appropriately before that. And then establish clear boundaries and rules like we had talked about. Parental disapproval is a huge protective factor. So making sure you tell them, I don't want you to smoke marijuana. I don't want you to use carts. And last point, knowledge is power. There is hope. We know a lot of what we've shared today is kind of a little anxiety provoking, but there is, like we said early on, there's a lot of information out there. It's kind of going through your resources, making sure it's a good resource and using it to educate yourself and educate your children, student, nieces, nephews, whoever about this topic. And here's our resource page. You can Google any of this information, any of these websites. SAPs fall under the Office of Student Safety and Wellness. There's a great website attached with the SAW office. We're also information on us can be found under Fairfax County Public Schools Alcohol and Other Drugs website. Our phone number is also there, 571-423-4270. You can call and find out which SAPS is responsible for your students' pyramid, and then get more information through your SAPS as well. And then the rest are pretty standard resources that we like to add to all the presentations. All right, well, thank you all so much for joining us. We hope we were able to clarify some questions you may have had before this on THC oil. And again, we thank you so much for joining us.
Thank you.
Thank you.